Welcome back to the Keeping It Simple series. This lecture is going to be on the upper extremity. Let's start off by talking about the bones and joints of the upper extremity, starting first with the humerus. Let's start off talking about the humerus by talking about the top of the humerus, or this surgical neck of the humerus. The surgical neck is important because it has clinical significance, because two very important things run through there, okay? Your axillary nerve, as well as your anterior and posterior circumflex artery. Your axillary nerve and your anterior and posterior circumflex artery are at the surgical neck of your humerus. Surgical neck of your humerus has your axillary nerve. We'll talk about that in detail in the brachial plexus lecture, as well as your anterior and posterior circumflex artery. The posterior body of the humerus has what we call the radial groove, and in the radial groove runs the radial nerve. And we'll talk about the radial nerve in detail here when we talk about the brachial plexus. So, the posterior body has this groove called the radial groove, which houses the radial nerve, all right? If you fracture the body of your humerus, you can have radial nerve injury or injure your deep brachial artery, okay? All right, the surgical neck houses your axillary nerve, your posterior body. The body of your humerus houses the radial nerve. Surgical neck houses which nerve?
Axillary nerve.
Excellent. And posterior body houses which nerve?
Radial nerve.
Excellent. Your medial epicondyle, you see a picture of it there, that's where your ulnar nerve is, okay? Your ulnar nerve is is in your medial epicondyle. Your medial epicondyle has your ulnar nerve. Your medial epicondyle of your humerus has which nerve?
Ulnar.
Ulnar, excellent. So we have surgical neck has your axillary nerve. Posterior body has your radial nerve. Medial epicondyle has your ulnar nerve. Let's talk about the ulna. You see the olecranon there? Okay, that's your olecranon bursa, and you can have what we call olecranon bursitis, which is inflammation there, right? If you fracture your olecranon, okay, you can fracture your olecranon by falling on your forearm if you're with a flexed elbow, right? So kind of like this, okay? So you can fracture that olecranon there. Upper extremity injuries, let's talk about nursemaid's elbow. What's nursemaid's elbow? What's dislocated elbow? The radius is displaced from your angular ligament, okay? So this will be something that can result from yanking a child's pronated arm. So if a child has a pronated arm, you start yanking it, you can dislocate this elbow by displacing it from the annular ligament, okay, and we call that nursemaid's elbow. Radius is displaced from the annular ligament. The radius is displaced from which ligament? Annular. Radius is displaced from which ligament? Annular. Excellent. So what happens when you dislocate your elbow, okay, and your radius is displaced from this annular ligament, you have a flexed and pronated forearm that's held close to the body. Let's talk about Colles fracture. Colles fracture is a fracture of the distal part of your radius. So this can happen if you fall on an outstretched hand with an extended wrist. So if you fall like this, you can fracture the distal part of your radius, leading to what we call Colles fracture, and you'll see this more commonly in older women who have osteoporosis. So anytime you see these bone fractures and lesions, bone fractures and breaks, you're going to commonly see that it's more common in people who have osteoporosis because they have weak bones. So that's just kind of a thing you should know. Let's talk about the bones of the upper extremity, your carpal bones. We have a little mnemonic for this, and start with your scaphoid bone there. So S for scaphoid, L for lunate. Then you have your triquetrum and your pisiform. So you have S, L, TP covered there. Okay, that's the bottom part of your carpal bones. Okay, then you go on top. That's your trapezium, trapezoid, capitate, and hamate. Okay, let's talk about injuries of your carpal bones then. So you can fracture your scaphoid. How do you fracture your scaphoid? You would be falling on an outstretched hand. Okay. And you'll have pain and tenderness in your snuff box, okay? Snuff box is a high-yield area and is very clinically relevant, so you see a picture of it there. The arrow is pointing to the snuff box, okay? So you fall on an outstretched hand, you can fracture your scaphoid, okay? Now here's the trick about it. Not only will you have pain and tenderness in your snuff box, but the x-ray may not show this fracture, okay? So having an x-ray and it being negative for it does not mean you don't have this fracture. Not treating the fracture then can lead to avascular necrosis. So that can be catchy, right? That can be tricky, right? Because it may not show up in an x-ray, but if you don't treat it, okay, then it can result in avascular necrosis. So fracture of the scaphoid, when not treated, can lead to avascular necrosis. So there's three things I want you to know. Scaphoid, snuff box, avascular necrosis. Scaphoid, snuff box, avascular necrosis. Scaphoid, snuff box, avascular necrosis. Scaphoid,
Snuff box. Avascular necrosis.
Scaphoid,
Snuff box. Avascular necrosis.
Excellent. Fracture of the hook of hamate. Okay. Your ulnar nerve, we'll talk about in the brachial plexus lecture, is located under the hook of hamate. Okay. So your ulnar nerve is located under your hook of hamate. So if you fracture the hook of hamate, you can have ulnar nerve injury, and the sign here of a fracture or the symptom presenting will be pain aggravated by a closing fist. So if they try to close their fist and the pain gets worse, you're starting to think about a fracture of the hook of hamate. Lunate dislocation. Lunate dislocation is important because it's the most commonly dislocated carpal bone, and it's important because that dislocation can lead to median nerve injury. Lunate dislocation can lead to median nerve injury. So look, hook of hamate, ulnar, lunate, median. Hook of hamate, ulnar, lunate, median. Hook of hamate,
ulnar,
hook of hamate, lunate,
median,
hook of hamate, lunate,
median.
Excellent. Boxer's fracture, just like it sounds. Punching, hit something, fracture. Most commonly involves the 4th and 5th metacarpal bones, okay? What do you see? Well, you're going to see tenderness and swelling on the medial side of your hand. Tenderness and swelling on the medial side of your hand. We call that boxer's fracture, just like it sounds. Let's talk about the muscles of the upper extremity. Let's talk about the rotator cuff. Mnemonic for this is sits. Say sits.
Sits.
First S, supraspinatus, infraspinatus, teres minor, subscapularis. Supraspinatus, infraspinatus, teres minor, subscapularis. Okay? Sits. The S stands for?
Supraspinatus.
I stands for?
Infraspinatus.
T stands for?
Teres minor.
And the last S stands for?
Subscapularis.
Subscapularis. Excellent. The most commonly injured muscle of your rotator cuff is going to be the first S, your supraspinatus, okay? That's what we call a positive empty can test. Positive empty can test. Okay? Now, we talk about abduction of the arm in detail when we get to brachial plexus, but there's certain things you need to know which muscle handles abduction at which degrees, okay? So we're going to talk about that now. I'm going to mention it and we're going to drill it together so we really understand it because this is a high-yield topic. Okay, so keep in mind, even though I'm giving you the degrees, they're probably not going to mention the degrees, they're going to describe it to you. Okay, so let's go. Abduction of your arm, that means abduction, you're taking your arm away from your body, abducting, right? 0 to 15 degrees is your supraspinatus, 0 to 15 is supraspinatus, 15 to 90 is deltoid, 15 to 90 is deltoid, 90 to 180 is trapezius and serratus anterior. 0 to 15 degrees is which muscle?
Supraspinatus.
And 15 degrees and 90 degrees is which muscle?
Deltoid.
And 90 to 180 degrees is what?
Trapezius and serratus anterior.
Excellent. So 0 to 15 degrees is your supraspinatus, 15 to 90 is your deltoid, and 90 to 180 is your trapezius and serratus anterior. Let's talk about the different compartments of the arm. Let's talk about the anterior compartment first. The anterior compartment of your arm houses the flexors of your elbow. It houses the flexors of your elbow, your biceps brachii muscle. Flexors of your elbow, biceps brachii muscle, which serves as a supinator of your forearm, and that's important because clinical relevance here is that it's innervated by your musculocutaneous nerve, which we'll talk about in the brachial plexus lecture. So the biceps brachii is innervated by the musculocutaneous nerve. Posterior compartment, so your anterior houses your flexors, so your posterior houses your extensors. So you have your extensors of your elbow here, and your innervation for the extensors is your radial nerve. Extensors of your elbow are innervated by your radial nerve. Let's talk about the anterior compartment now of your forearm. The anterior part houses your flexor. So you see the pattern here? The anterior arm had your flexors. Now the anterior forearm has your flexors, right? So these originate from the medial epicondyle of your humerus, okay? And they're two different groups. So you have the medial aspect and the lateral aspect. The medial aspect is innervated by your ulnar nerve. The lateral aspect is innervated by your median nerve. Medial aspect, ulnar nerve. Lateral aspect, median nerve. Don't get confused and start telling me that medial is done by median. Okay? It's an easy mistake to make. So, the medial aspect is done by your ulnar nerve, and your lateral aspect is done by the median nerve. This is high yield. It's very high yield. And we're going to talk about ulnar claw hand and median claw hand. You're going to need to understand this in order to understand that. The medial aspect is innervated by the ulnar nerve. The lateral aspect is innervated by your median nerve. Medial aspect is innervated by which nerve? Ulnar. And your lateral aspect is innervated by which nerve? Median. Excellent. All right, let's talk about the posterior compartment of your forearm. So we had the anterior compartment of your arm, right? And that had your flexors. Then we had the anterior compartment of your forearm that had your flexors. We had the posterior compartment of your arm that had extensors, and now we're at the posterior compartment of your forearm, which also has extensors. But now it's extensors of the wrist, because we're talking about the forearm. So the posterior compartment has extensors of your wrist, and these originate from the lateral epicondyle of your humerus. These extensors, the extensors of your wrist are innervated by radial nerve. Extensors of your wrist are innervated by the radial nerve. Extensors of your wrist are innervated by which nerve? Radial. Extensors of your wrist are innervated by which nerve? Radial. And that's why radial nerve injury results in wrist drop. Okay? So if you have a injury to this lateral epicondyle, it'll present with pain and tenderness, and that's what we call tennis elbow. The supinators of your forearm are also innervated by the radial nerve. The supinators of your forearm are also innervated by the radial nerve. The supinators of your forearm are innervated by which nerve? Radial. So your radial nerve is innervating the extensors of your wrist and the supinators of your forearm. Okay, hand muscles. We talk about these also in the brachial plexus lecture. Let's talk about our thenar eminence. Thenar eminence, muscles for your thumb. Okay, innervated by the median nerve, but more specifically, they're innervated by the recurrent branch of your median nerve. So your thenar eminence is innervated by your median nerve. Which nerve? Median. Excellent. Your thenar eminence is innervated by which nerve? Median. But more specifically, there's a branch of the median nerve, and the name of that branch is? Recurrent. The recurrent branch. Excellent. Then we have the hypothenar eminence, which is next to your thenar eminence. Okay, TH for thenar, TH for thumb. This is next to your, thenar eminence is next to your thumb. Hypothenar eminence is next to your thenar eminence. So these have muscles for your small finger, okay? Muscles for your small finger, and these are innervated by the ulnar nerve. So your hypothenar eminence is innervated by the ulnar nerve. The hypothenar eminence is innervated by which nerve? Ulnar. Ulnar, excellent. Let's talk about your lumbricals. Your lumbricals help with metacarpophalangeal joint flexion. You have 2 lateral lumbricals, 2 medial lumbricals. Pay attention here, because it's going to come in, it's going to come in relevance again when we talk about median and ulnar claw hand. Okay, and those can get tricky because the descriptions sound similar, but they look different, and they're easy points on a test to miss. Okay, but they're also easy points on a test to get if you just understand where these nerves are. So, the 2 lateral lumbricals and the 2 medial lumbricals. The 2 lateral lumbricals are done by the medial nerve, and the 2 medial lumbricals are done by the ulnar nerve. Don't get confused again and start telling me that median is medial. Okay? The 2 lateral lumbricals are innervated by the median nerve, and the 2 medial lumbricals are innervated by the ulnar nerve. The 2 lateral lumbricals are innervated by which nerve? Medial. What about the 2 medial lumbricals? Ulnar. Excellent. So lateral, median, medial, ulnar. Okay, lateral, median, medial, ulnar. Remember that. Interosseous muscles. The dorsal interosseous muscles are responsible for abduction of your fingers. The palmar interosseous muscles are responsible for adduction of your fingers. So dorsal, abduction, palmar, adduction. Dorsal, abduction, palmar, adduction. Dorsal, abduction. Dorsal, abduction. And palmar, adduction. Palmar, adduction. So dorsal, abduction. And palmar, adduction. And these are all innervated by the ulnar nerve. These interosseous muscles are innervated by the ulnar nerve. The interosseous muscles are innervated by which nerve? Ulnar. Ulnar nerve. Excellent. Let's talk about Dupuytren's contracture. Dupuytren's contracture. Thickening of the palmar aponeurosis. Thickening of the palmar aponeurosis. Excellent. So what happens? You have flexion of your affected digits. Flexion of your affected digits, and they're most commonly going to be your 4th and 5th digits. What is this associated with? When can you have this thickening of the palmar aponeurosis? You can have it, and it's associated with coronary artery disease, alcoholic cirrhosis, or it could be hereditary in this autosomal dominant pattern here. It's structural. Remember, structural is usually autosomal dominant. Enzyme is usually autosomal recessive. This is a structural issue, so it's going to be autosomal dominant. So, associated with coronary artery disease, alcoholic cirrhosis, as well as it could be hereditary with an autosomal dominant pattern. Let's talk about the vessels of the upper extremity. Let's talk about the brachial artery. Branches. Deep brachial artery. Radial groove of your humerus. Okay? The other branches, ulnar artery and radial artery. So look, your brachial artery has your deep brachial artery, and the other branches are ulnar artery and radial artery. In the hand, they branch again to your superficial palmar branch and your deep palmar branch. Let's talk about the nerves of the upper extremity. The brachial plexus extends from C5 to T1. That's C5 to T1. So we have C5, C6, C7, C8, and T1. So the way to do it is take your hand out, take your thumb, that's C5, C6, C7, C8, T1. So you take your hand out and you go from C5 to T1 on your hand, starting with the thumb, ending with your pinky. Now I see lots of mnemonics for the brachial plexus. What we did, we decided to stick with the theme of drinking and alcohol for these mnemonics. So we're going to go ahead and get started with our mnemonic. All right, reach to drink cold beer. Repeat after me. Reach to drink cold beer.
Reach to drink cold beer.
Perfect. Reach to drink cold beer. Roots, trunks, divisions, cords, branches. Ready? Roots.
Roots.
Roots, trunks.
Trunks.
Roots, trunks, divisions.
Roots, trunks, divisions.
Roots, trunks, divisions, cords, branches. One at a time. Roots.
Roots.
Trunks.
Trunks.
Divisions.
Divisions.
Cords.
Cords.
Branches.
Branches.
Reach to drink cold beer. Your R, T, D, C, B. Roots, trunks, divisions, cords, branches. Now that we've talked about it, let's talk about how to draw it, and we'll see how it all fits in. The easiest way to draw the brachial plexus is to start on a sheet of paper, and write from C5 down to T1 on the left side, just like that. C5, C6, C7, C8, T1. All right. Then you're going to draw 3 Ys. All right. The Y in the middle faces the opposite direction. So you're going to draw 3 Ys. The Y in the middle faces the opposite direction. So you write down C5 or T1 and you draw 3 Ys. After you draw the 3 Ys, you're going to draw 2 Es. Okay. So 3 Ys and 2 Es. Remember, 3 Ys, the Y in the middle faces the opposite direction, and then you have 2 Es. Once you draw the 3 Ys and the 2 Es, you're going to throw in an X, as such, in between C6 and C7. Then you're going to come in and label using our mnemonic that we said, reach to drink cold beer, roots, trunks, divisions, chords, branches. So you have 3 Ys, 2 Es, and our mnemonic on top, and we fill in roots, trunks, divisions, chords, branches. Reach to drink cold beer. Now let's talk about the individual parts of the brachial plexus. We have another mnemonic here, and this one's also related to alcohol. So I wanted to keep the theme consistent. So if you reach to drink enough cold beer, you might have to urinate, right? So, most alcoholics must really urinate. Repeat after me. Most alcoholics must really urinate.
Most alcoholics must really urinate.
Excellent. Well done. So most alcoholics must really urinate. So once you figure that out, you see, you're going to draw the things in. You're going to write the nerves down from top to bottom, going zigzag. So every time you see a break, you're going to write down the name of the nerve. So start with musculocutaneous, go to axillary, median, radial, ulnar. So that's the mnemonic. Most alcoholics must really urinate. Musculocutaneous, axillary, median, radial, and ulnar. Now don't worry about all those right now because we're going to do them one at a time. I'm just showing it to you here all together, but we're going to break it down and go one step at a time. The one thing you probably see on the left side here is a line that says long thoracic nerve. It's from C5, C6, and C7. Everybody's probably heard, 5, 6, 7, wings to heaven. Well, the reason they say that is because if you injure your long thoracic nerve, you have winging of the scapula. So just know that here. We're going to talk about it in detail later. From C5, C6, C7, you've drawn a line, and that is your long thoracic nerve. So in summary, you've talked about reach to drink cold beer, your roots, trunks, divisions, chords, branches. You drew 3 Ys and 2 Es and an X, right? And then you drew a line for the long thoracic nerve. We talked about the mnemonic. Most alcoholics must really urinate, so let's talk about that M. Most, and the most alcoholics must really urinate, the first M stands for your musculocutaneous nerve, and you see it in green there on your slide. The musculocutaneous nerve, the course of this nerve is in your anterior arm, and it exits laterally in your forearm. The course of this nerve is your anterior arm, and it exits in your lateral forearm. Anterior arm is where it is, but the motor is what I want you to focus on. It's the anterior flexor compartment of your arm. It's the anterior what?
Flexor.
Excellent. Anterior?
Flexor.
Anterior flexor compartment of your arm, and you'll see where that comes into play here in a second. Sensory is pretty straightforward. It's your arm and lateral forearm. But check this out. Musculocutaneous kind of sounds like that word muscle, right? Spelled similarly. So if you injure your musculocutaneous nerve, you can't flex your elbow and show off your muscles. Okay? Remember we talked about how motor supplies the anterior flexor compartment of your arm. So if you injure your musculocutaneous nerve, which runs in the anterior part of your arm, if you injure this nerve that sounds like muscle, looks like muscle, you can't flex and show them your muscles, okay? So injury to the musculocutaneous nerves means you
cannot flex elbow.
Excellent. You can't flex your
Elbow.
and the nerve is musculocutaneous, and it means you can't flex your elbow. All right? Most alcoholics must really urinate. A for axillary. Let's talk about the axillary nerve. The axillary nerve runs posterior to the surgical neck of the humerus. What part of the humerus? It's the surgical neck. What part of the humerus? What part of the humerus? The surgical neck. And the nerve is? And it runs next to what? Surgical neck. It runs behind the surgical neck. So its axillary nerve is posterior to the surgical neck of the humerus. Now, motor supply to 2 muscles. Your deltoid and teres minor. Your deltoid and? Teres minor and? Axillary nerve supplies 2 muscles. Your deltoid and? Teres minor and? And what part of the humerus is it behind? The surgical neck. Your axillary nerve is behind the surgical neck of your humerus. It supplies your deltoid and your teres minor. Sensory. Well, axilla, it's your armpit, right? So it's pretty simple. Sensory is your shoulder. Sensory is your shoulder. Now, the reason why I kept having you say surgical neck is because it's a great clinical question for them to ask you, and they will. Injury is surgical neck fracture. So if you have a surgical neck fracture, you can injure your axillary nerve. Your axillary nerve, when injured, will prevent you from abducting your arm. What's abducting your arm? Well, abduct. If a girl gets abducted, if a kid gets abducted, that means they're taken away from home. Abducting your arm, therefore, means you're taking it away from your body. Okay? So this is abduction of your arm. This is going to prevent abduction from 15 degrees to 90 degrees. From 15 to 90. The axillary nerve is responsible for abduction from 15 to 90. From 15 to? 90. The nerve is? And it's abduction from what to what? 15 to 90. Does abduction for 15 to 90. From 15 to 90. From?
15 to 90.
Excellent. Know that because they like to ask you. Okay? And they won't say 15 to 90. They might describe it. Okay? So 15 to 90 is from here to here. All right? So your axillary nerve, we said it runs posterior to your surgical neck of the humerus. Motor, deltoid and teres minor. Sensory to your shoulder. And when that nerve is injured in a surgical neck fracture, it can lead to loss of abduction from 15 degrees to 90 degrees. Most alcoholics must really urinate. We're on the second M now. This is probably one of the most important nerves of the brachial plexus, your median nerve. Okay, your median nerve. The median nerve runs anterior to your elbow, and it supplies and passes between your pronator teres muscle. Okay, all that's not all important. I just want you to know that it runs anterior to your elbow. It runs anterior to your elbow. The median nerve runs anterior to your elbow, and it runs in between the two heads of your pronator teres muscle. Well, pay attention, because like I said, this is one of the most important nerves of the brachial plexus. Not only for exams, but also in clinical practice, and you'll see that in a second. Motor. In your forearm, it supplies your lateral flexors of the wrist. The lateral flexors of the wrist. The lateral
Flexors
of the
wrist.
The lateral
Flexors
of the
wrist.
And the nerve is?
Median.
Median nerve supplies the lateral flexors of your wrist. In your hand, it supplies your two lateral lumbricals. Your two lateral lumbricals. Your two?
Lateral lumbricals.
Excellent. So you have motor in your forearm to your flexors of your wrist. In your hand, two lateral lumbricals. And your thenar eminence. Your thenar eminence, TH, is next to your TH thumb. Okay? So thumb TH, thenar TH. Your thenar eminence is next to your thumb. And that's important. So I'm going to tell you again. It supplies your thenar eminence. Which eminence?
Thenar.
Which one?
Thenar.
Excellent. Your thenar eminence via a branch called the recurrent branch. Thenar ends in R. Recurrent starts with R. The median nerve has a branch called the recurrent branch which supplies the thenar eminence. Which branch of the median nerve supplies your thenar eminence? Which branch? Which branch of the median nerve supplies your thenar eminence? Recurrent branch of your median nerve. Sensory. Now this is important, and they're going to ask you this. They're going to have you distinguish this between your ulnar nerve or the radial nerve. So pay attention. So the median nerve, sensory, supplies your lateral 3 1/2 fingers, the palmar part, and the superior dorsal aspect. What does that mean? Your fingertips. Fingertips. Okay? So palmar aspect, lateral 3 1/2 fingers, and superior dorsal aspect, which is your fingertips of those same fingers. Injury. 3 types of injury that can occur to your median nerve. Carpal tunnel syndrome, supracondylar fracture of your humerus, and lunate dislocation. So, we're going to repeat these things in order. Carpal tunnel, supracondylar fracture,
Supracondylar fracture.
lunate.
Lunate.
Excellent. So carpal tunnel syndrome, supracondylar fracture, as well as lunate dislocation. What happens when it gets injured? Median nerve injury results in thenar atrophy. We said that the recurrent branch of the median nerve supplies your thenar eminence. So if you injure your median nerve, you're going to have thenar atrophy. You're also going to have loss of thumb opposition. Now, you're going to have median claw hand. Now, there's 2 types of median claw hand. It can get a little confusing. So see if you can follow me. So you have distal lesion or proximal lesion. Distal means further away, proximal means higher up. So if the distal lesion is in your hand after you receive innervation for your forearm muscles, and you lose your 2 lateral lumbricals, okay? So you ask your patient here to open your hand. So distal, D-O, open your hands, D-O. Distal, open your hands, okay? You're going to open your hands, and your 2nd and 3rd digit are going to stay flexed. Your 2nd and 3rd digit are going to stay flexed, and it's going to look like this. All right. Proximal lesion now. The proximal lesion is in the arm or upper forearm. Therefore, we lose muscles that innervate the flexors of the fingers. So this is what happens. I try to punch somebody. Try to make a fist to punch somebody, but instead you end up blessing them. Okay? Instead you end up blessing them, and it looks like this. So you're going to lose your 2 lateral lumbricals. You're going to lose loss of muscles of thumb opposition, And when a patient makes a fist, the lateral lumbricals will stay extended, as well as the thumb. That description sounds complicated, but just take a look at how it looks. And the proximal lesion is different from the ulnar lesion because in the ulnar claw hand, the thumb can still flex, but in the proximal lesion to the median nerve, medial claw hand, proximal medial claw hand, your thumb cannot flex. In ulnar claw hand, it can. And once again, the proximal lesion of the median nerve looks like this. The distal lesion of the median nerve looks like this. Now, we talked about the injury. We talked about carpal tunnel syndrome with the median nerve. Well, what happens? What causes it? Tendinitis of flexor retinaculum. Tendinitis of your flexor retinaculum due to overuse. Tendinitis of a ligament called the flexor retinaculum. The ligament's name is flexor retinaculum. The name of the ligament is? Flexor? Excellent, because they might not ask you median nerve. It's too easy. They might ask you this, so you know it now. Right? So that leads to median nerve entrapment, and you'll see the following findings. Numbness, tingling, sensory loss, or atrophy or atrophy of your thenar eminence. We already talked about the thenar eminence. I want to ask you one more time. What branch of the median nerve innervates your thenar eminence? The recurrent branch of your median nerve supplies your thenar eminence. So when that median nerve gets injured, that thenar eminence no longer has that supply. So it'll become atrophic. It'll flatten out. So you also see numbness and tingling or sensory loss. So you'll see a lot of people who use their wrist too much, right? Video game players, people who type a lot. Okay, so if you have bilateral carpal tunnel syndrome, you can suspect one of the following things. Mnemonic is median trap. Repeat after me. Median trap.
Median trap.
Median trap.
Median trap.
Let's talk about it together. M for myxedema. E for edema. D for diabetes. M for? E for? D for?
Diabetes.
Excellent. IAN. Idiopathic. Acromegaly. N. I for?
Idiopathic.
A for?
Acromegaly.
N for?
Neoplasm.
Let's do all the median together. M for?
Myxedema.
E for?
Edema.
D for?
Diabetes.
I for?
Idiopathic.
A for?
Acromegaly.
N for?
Neoplasm.
Trap. We got median. Now it's time for trap. T for trauma. R for rheumatoid arthritis. A for amyloidosis. And P for pregnancy. Trap. T for?
Trauma.
R for?
Rheumatoid arthritis.
A for?
Amyloidosis.
And P for?
Pregnancy.
Excellent. Most alcoholics must really urinate. Most alcoholics must really urinate. Now we're on the R, and the R stands for radial. So we did musculocutaneous, we did axillary, we did median. Now it's time for radial. Your radial nerve, simple, the radial groove in your humerus. That's the posterior part of your humerus. It's even called a radial groove, and that's what your radial nerve is. It's motor to three things: triceps, brachioradialis, extensors of your wrist. Triceps, triceps, brachioradialis, extensors of the wrist. What part of the wrist? What part of the wrist? So triceps, brachioradialis, and extensors of your wrist are all supplied by this radial nerve, which runs in the posterior part of your humerus in a groove called the radial groove. Sensory supply, radial nerve has sensory supply are two parts. Your posterior arm and forearm, the back of your arm and forearm, posterior arm and forearm, and you should know that because it runs in the posterior part of your humerus. So it's in the back and it's sensory supply to your arm and your forearm. Also, we talked about the median nerve being the sensory supply to your lateral fingertips of your 3 1/2 fingers. This is below your fingertips. So the median nerve did the fingertips, the radial nerve does below the fingertips. What does the fingertips? Median. What does below the fingertip? What did fingertip? What is below fingertip? Excellent. So how do you injure the radial nerve? You can fracture the body of your humerus. We talked about the surgical neck earlier. That was separate. This is now the body of your humerus. What part of the humerus? Body. So radial nerve can be injured in fracture of the body of your humerus, as well as what we call Saturday night palsy, which is compression of the nerve in your axilla. Compression of nerve in your axilla, as well as using crutches which are improperly adjusted. So, three things. Fracturing what part of the humerus? The body. And then we have Saturday night palsy, which is just compression of your nerve in your axilla, as well as using improperly adjusted crutches. Now, when you injure your radial nerve, you get wrist drop. Radial nerve, wrist drop. Radial nerve, radial nerve, radial nerve. Excellent. Most alcoholics must really urinate. To the last part, ulnar. Your ulnar nerve. Your ulnar nerve is posterior to your medial epicondyle. Posterior to your medial epicondyle. You'll see a picture of it in a second. It's posterior to? Posterior to? Superficial to the flexor retinaculum ligament. Okay, and we talked about that when we talked about the median nerve just a second ago. Motor. Well, what does the ulnar nerve supply? It innervates the medial flexors of your wrist. The medial flexors of your wrist. Now we talked about the median nerve, how it supplies your thenar eminence, right? So next to your thenar eminence, we have the hypothenar eminence, and the hypothenar eminence is supplied by your ulnar nerve. So TH for thenar, TH for thumb. Thenar eminence is by your thumb. This is your hypothenar eminence. So your hypothenar eminence and your third and fourth lumbricals. Which lumbricals? Third and fourth. Which lumbricals?
Third and fourth.
Which lumbricals?
Third and fourth.
Third and fourth. So what do we have so far? Medial flexors of your wrist, hypothenar eminence, third and fourth lumbricals, and all the interosseous muscles of your hand. Now, sensory. Pay attention. This is important. This is where it distinguishes it from the median nerve. This is sensory to your dorsal and palmar aspect of your hand for your medial 1.5 fingers. This is what's important with the ulnar nerve. This is what I want to talk about. I said it runs by the medial epicondyle, right? So you can fracture your medial epicondyle, lead to injury of the ulnar nerve, as well as fracture of the hook of hamate. So two things, medial epicondyle fracture and fracture of the hook of hamate. This results in the inability to abduct or adduct your fingers. It results in the inability for you to adduct or abduct your fingers. You cannot abduct them, you cannot adduct them. Because the ulnar nerve supplies the hypothenar eminence, you're going to have hypothenar atrophy. And you're going to have ulnar claw hand. What's ulnar claw hand? Ulnar open. So, you're going to have loss of your medial lumbricals. Your patient tries to open the hand and they cannot extend the fourth and fifth digits. Ulnar claw hand, you cannot extend the fourth and fifth digits. The ulnar claw hand, you cannot extend the fourth and fifth digits, but you can still flex your thumb. Okay? Right? So median nerve is thenar atrophy. This is hypothenar atrophy. This is your ulnar nerve. So we talked about the nerves. We talked about the nerve's injuries. Let's talk about lesions of the plexus. Herb Duchenne palsy. Herb Duchenne palsy is your upper trunk lesion, C5 and C6. Upper trunk lesion, Herb Duchenne, C5, C6. Herb Duchenne, C5, C6. Herb Duchenne? Herb Duchenne? C5, C6. Well, what happens? It can be caused by trauma or traumatic birth. This is your upper trunk lesion, your Herb Duchenne, C5, C6, and it leads to your limb hanging by the side, immediately rotated, pronated forearm. So the way I remember this one is that Duchenne has a U in it, upper trunk has a U in it, Klumpke's has an L in it, lower trunk has an L in it. That's how I remember which one does what. So let's talk about Klumpke's. Klumpke's is a lower trunk lesion, C8T1. Herb Duchenne was C5, C6, Klumpke's is C8T1. Klumpke's, C8T1. Klumpke's? C8T1. Klumpke's? C8T1. Excellent. This Hanco's tumor or traumatic birth. So when you think about Klumpke's, C8T1, you think about RUM, R-U-M, radial, ulnar, and median nerves. Now, because all three nerves are affected, you're going to lose all of your lumbricals and all of your fingers are going to be clawed. So Klumpke's leads to all fingers clawed. All fingers are clawed in? All fingers are clawed in? And it's from C8 to T1. So all of your lumbricals, so all of your fingers are clawed, and you're going to also lose the flexors and extensors of your forearm. The lower extremity. Start off with the bones and joints. All right, let's talk about the femur. So we're talking about bones, we'll start off with the femur. The head of the femur has its own blood supply. The head of the femur has its own blood supply, and the name of that artery that supplies the head of the femur is called the medial circumflex femoral artery. So we're talking about the femur, right? So we have femoral, okay? This is medial circumflex femoral. The head of the femur has its own blood supply. It's the median circumflex femoral. Let's repeat after me. Medial circumflex femoral. Medial circumflex femoral. Your turn. Medial circumflex femoral. One more time. Medial circumflex. And it supplies what part of the femur? The head. There's another one. It's a branch of your obturator artery. And get familiar with that artery because they love to ask about the obturator artery. They love it. It's very high yield. So we're talking medial circumflex femoral. Now we're talking about a branch of the obturator artery. So the head of the femur has two parts of its blood supply. We already talked about medial circumflex femoral, and now it's a branch of the obturator. Branch of? Excellent. This is a ligament in the head of the femur, okay? And this is important because it supplies the growth plate. So if you're an infant, right, or if you have an infant, and they injure their femur, or they injure this branch of the obturator artery, it can inhibit growth. And so that's your clinical significance there of this part of the blood supply. So when repeating this one more time, the head of the femur has its own blood supply, two arteries, your medial circumflex femoral, which runs posterior to the neck of the femur, as well as a branch of the obturator artery, which runs in a ligament in the head of the femur. Femoral neck fracture. This is common in women with osteoporosis because they have weak bones, right? That's what we say. Now, if you have a femoral neck fracture, you have a risk of injury to your medial circumflex femoral artery. Well, if you fracture the body of the femur, okay, you can have anterior displacement. Anterior means forward, right? So if it's a forward displacement, you can injure your femoral nerve and artery. So anterior displacement of your femur can lead to injury of your femoral nerve and artery. Your femoral and femoral nerve and artery and excellent. So if you have anterior displacement of this femur, you can injure your femoral nerve and femoral artery. Leg calves purse disease. So it happens in people that are 3 to 10 years of age, and it's avascular necrosis of the head of your femur, so your femoral head. So avascular necrosis of the femoral head, and we talked about the femoral head, we talked about the blood supply. So if you have avascular necrosis of the femoral head, we call that leg calves purse disease. Now, what are you going to see in leg calves purse disease? Well, it's a painless limp. It starts off painless and then it progresses to painful. So it's a gradual onset of pain. So when you have this avascular necrosis of your femoral head, okay, you're going to have a painless limp at first, and then it can progress to painful. So it's a gradual onset of pain, right? It can radiate to your groin and knee. So you have this painless limp, gradual onset, and it can radiate to your groin and knee. It can radiate to your and radiate to your and to your. So if you have a painless limp, it becomes a painful limp, and the patient complains of this painful limp with pain in their groin or knee. You want to start thinking about leg calves purse disease, which is due to avascular necrosis of the femoral head. Now, on the x-ray, what are you going to see? You're going to see delayed bone age on x-ray. So you have a couple things you need to keep in mind. Gradual onset of pain that can radiate to your groin and knee, and delayed bone age on x-ray. Delayed bone age on x-ray, that's called leg calves purse disease. Let's talk about congenital hip dysplasia. What is that? Well, first of all, it's more common in females. Okay? All hip pathologies are more common in males except congenital hip dysplasia, which is more common in females. So all the hip pathologies are more common in males except for this one, which is going to be more common in females. What's the cause? Breech deliveries. The cause is breech deliveries. What do you find? Click on rotation of the hip. Okay? So congenital hip dysplasia, congenital with a C, click with a C. Congenital click. Say it. Congenital click.
Congenital click.
Say it again.
Congenital click.
Congenital click. Okay? As well as asymmetrical creases on the back part of the thighs or the posterior part of the thighs. So the creases are no longer symmetrical, and you hear a click on rotation of the hip. All hip pathologies are more common in males except for this one, which is more common in females. Slip femoral epiphysis. This is seen in overweight and obese children. Seen in overweight, obese children between 9 and 13 years of age. Okay? And what's the clinical importance of this? What's the clinical importance of this? Well, people who have slip femoral epiphysis have greater risk of developing osteoarthritis. They have greater risk of developing osteoarthritis. They have greater risk of developing osteoarthritis. They have a greater risk of developing osteoarthritis. And in one thing that's different from when we talked about legs, calves, purse disease, in this one you're going to have a painful limp from the get-go. A painful limp here. Okay? This is going to be a painful limp, not a painless one that gradually progresses. This is going to be a painful limp. So, we can have dislocation of the hip also. If you have dislocation of the hip, chances are it's been dislocated posteriorly, because that's the most common one. The most common one is posterior dislocation of the hip. And it's usually caused by trauma, okay? So what are you going to find? You're going to find a shorter limb. One of the limbs is going to be shorter, uneven limbs. Now, let's talk about the posterior one and the anterior one separately, because there's nerves that can get injured in each case. We're going to talk about those nerves. So posterior hip dislocation, which is more common than the anterior one, you can injure two nerves, sciatic and superior gluteal. Sciatic and superior gluteal. So you have posterior dislocation of your hip, you're worried about two nerves that can get injured, sciatic and superior gluteal. Which one? Sciatic and? Superior gluteal and? Sciatic and? Superior. And what kind of dislocation of the hip is that, anterior or posterior? Posterior. Posterior hip dislocation can lead to injury of your sciatic nerve, which is more common, or your superior gluteal nerve. If you have anterior hip dislocation, there's an anterior dislocation, you're worried about injury to your obturator nerve. So posterior, we have two nerves, the sciatic and the superior gluteal. Anterior, which is less common, you're worried about the obturator nerve. Which nerve? Obturator. Excellent. So if you have posterior hip dislocation, which two nerves can be injured? Sciatic and? Superior. Superior gluteal and? Sciatic. But if it's an anterior hip dislocation, which nerve are you worried about? Obturator. The obturator nerve. Excellent. Let's talk about Osgood-Schlatter disease. This happens to athletic people. People who are active between the ages of 10 to 15 years old. What do you see? Pain and tenderness on your tibial tuberosity. Okay. So people that are between 10 and 15 years of age are athletic, they're active, and the only sign and symptom you're going to see here, the only finding you're going to have is going to be pain and tenderness on your tibial tuberosity. Now with the knee, there's 4 ligaments that you have to know, and the injuries associated with them that are high yield, so pay attention. Well, you have anterior and posterior cruciate ligaments, Anterior and posterior, so your ACL and your PCL. And you have two collateral ligaments, your medial and lateral. Okay? So ACL, PCL, and then you have your medial, collateral, and lateral collateral. So there's 4 ligaments, 2 cruciates, 2 collaterals. Okay? The cruciate ones are anterior and posterior, and then the collateral ones are going to be medial and lateral. All right? So 4 ligaments: ACL, PCL, MCL, LCL. All right? Now, which ones do you need to know? We got to know the ACL injury, anterior cruciate ligament injury. How did this happen? Hyperextension of your knee can lead to an ACL injury, and that'll lead to a positive drawer sign. A positive drawer sign. All right? 2 menisci. You have a lateral meniscus and your medial meniscus. Your lateral meniscus joins the ACL. Okay? So if you injure either your lateral meniscus or your ACL, you can injure the other one. So if you injure your ACL or your lateral meniscus, right, you can injure the other one because the lateral meniscus joins your ACL. So injury to one can lead to injury to the other one. All right? Now this medial meniscus. Medial meniscus is your most commonly injured meniscus. Okay? So the most commonly injured meniscus is your medial one. But if your lateral one gets injured, you can also injure your ACL because they're joined. All right? Now, McMurray's test. What's the McMurray's test? This is internal and external rotation of your knee. And that means when you do this internal external rotation of your knee, it causes pain or popping in the joint. So if you have this internal external rotation of your knee, and you have pain or popping in the joint, we call that the McMurray's test. And if that happens and you have this pain or popping, that's positive for a meniscal tear. Okay? And if it's positive for meniscal tear, you're thinking about 2 menisci. The most commonly injured one is your medial menisci. The other one's a lateral one. If the lateral one gets injured, start worrying about the ACL. Everybody follow? Cool. Unhappy triad. Is injury to the knee from lateral impact. Okay? They love to ask this question. Talk about a soccer player or something. All right? Lateral impact to the knee. Unhappy triad. What happens? 3 things. MAL. MAL. Unhappy triad. MAL. Say it. MAL. Unhappy triad. 3 letters. Which ones? MAL. Excellent. Medial collateral ligament. Okay? Anterior cruciate ligament. And your lateral menisci. Okay? So your MCL and your ACL. Anytime your ACL gets injured, you're worried about your lateral menisci, right? So you really only have to remember 2 things. Your medial collateral ligament and your anterior cruciate ligament. Because anytime your ACL gets injured, we've got to worry about the lateral menisci. Let's talk about the Baker cyst. And this is important because it can present as something else. So you got to know the difference. A Baker cyst is a bulge in your popliteal fossa. It's an outpouching of your semimembranous or synovial bursa of the knee. Okay? It's an outpouching. Now what causes it? It's due to arthritis or a meniscal tear. Now, I know some of these things I'm just going past quickly, but that's because they're not that important. I focus on what is, and I'll make you repeat it. Baker cyst. It's a bulge in your popliteal fossa, and it's outpouching of semimembranous of synovial bursa of your knee. What causes it? Arthritis or meniscal tear. Let's review. Which menisci is most likely to get injured? The medial one. But if the lateral one gets injured, what you got to worry about? ACL. Excellent. Caused by arthritis or meniscal tear. Well, a rupture of this cyst can cause pain, redness, and swelling. That makes sense, right? If a cyst ruptures, it could hurt, and redness and swelling always follow. Well, why is this important clinically? Is because this can mimic a DVT. Okay? A Baker cyst can mimic a DVT. So that's your clinical pearl there, is DVT can present as Baker cyst and vice versa. So a Baker cyst is a bulge in your popliteal fossa due to outpouching. All right? It's caused by arthritis or a meniscal tear, and it mimics the symptoms of a DVT. Let's talk about the muscles of the lower extremity. Let's talk about the gluteus maximus. Well, the gluteus maximus is important because it's responsible for movements against gravity. Okay? Walking upstairs, getting out of a chair. Now, this next part is high yield. The gluteal muscle, the gluteus maximus, is innervated by the inferior gluteal nerve. The gluteus maximus is innervated by the inferior gluteal nerve. The gluteus maximus is innervated by what gluteal nerve? Inferior. The gluteus maximus is innervated by which gluteal nerve? Inferior. Inferior. So say maximus inferior. Maximus inferior. Maximus inferior. Maximus inferior. That's good. All right, let's talk about the gluteus minimus and medius. Now, the gluteus minimus, so we talked about the maximus. It's responsible for movements against gravity, like walking up the stairs. Now we're talking about the gluteus medius and minimus. This is responsible for abduction of your hip. Now here's the difference. We said maximus inferior, now we're at minimus superior. So a lot of people get confused because they think maximus superior. That's because they kind of go together, right, the terms? Not so, not in this case. Maximus inferior gluteal nerve gluteal minimus and medius innervated by the superior gluteal nerve. So, the gluteus minimus and medius are innervated by which gluteal nerve? Superior. And maximus is innervated by? Maximus is innervated by? But the minimus and medius are innervated by? Excellent. So the gluteus maximus is done by the inferior gluteal nerve, but the medius and the minimus are done by the superior gluteal nerve. This is your Trendelenburg sign. This is where it comes into place. It's clinically important and also important for your exam. Trendelenburg sign. Patient stands and picks one leg off the floor. Positive test is when the pelvis falls on the affected leg. So they're going to stand and pick one leg off the floor, and if the hip falls, okay, on the affected leg, that's positive for Trendelenburg sign. Now, they're going to ask you. They're going to describe a test and say what was injured, and you're going to say which nerve was injured?
Superior.
And which two gluteus muscles are innervated by the superior gluteal nerve? Minimus and medius. Excellent. The superior gluteal nerve can be injured in polio. Hip muscles. Let's talk about the hip muscle. Let's talk about the psoas muscle. The psoas muscle is the flexor of the hip. Okay, so what's the psoas sign? The psoas sign is you're going to have your patient lie down and extend their thigh, and if it hurts, okay, that might be indicative of appendicitis. Why is it indicative of appendicitis? Because the appendicitis is retrocecal. Okay, so it's retrocecal. So if somebody lays down, extends their thigh, and it hurts, that can be indicative of appendicitis, and we call that the psoas sign. And the psoas muscle, once again, is the flexor of your hip. All right, leg muscle. Let's talk about the extensions of your knee. We talked about the extensions of your knee earlier. We talked about the femoral nerve. The extensions of your knee are innervated by the femoral nerve. The extensions of your knee are innervated by which nerve? Femoral. Which nerve innervates the extensions of your knee? Femoral. Excellent. So the femoral nerve does the extensors of your knee, and the flexors of your knee, are innervated by your sciatic nerve. So the extensions of your knee are done by which nerve? Femoral. But the flexors are done by? Okay, so extensors, femoral, flexor, sciatic. Ready? Extensors, femoral, flexor, sciatic. Extensors, femoral, flexors, sciatic. Ready? Go. Try it again. Excellent. Now, why is that important? Remember, we talked about your hip dislocation. We talked about how it was posterior most of the time and two nerves can be injured. We said it was sciatic and superior gluteal. So here's a sciatic nerve, which is responsible for flexors of your knee. So just tying it back to what we talked about earlier. Your Achilles tendon, right? If you tear this tendon, you cannot plantar flex your foot. You cannot plantar flex your foot. Now, why is this important? Because this tendon is a big tendon. That means it's easy to be affected by medications. Fat-soluble medications can go where they need to go. They can cross membranes easily. This is a big tendon. It can cross into this big tendon easily. So a lot of medication, when you see tendinitis, right, will affect this tendon, this Achilles tendon. And you'll see that a lot when we talk about drugs like quinolones, which are very fat-soluble and cause tendinitis as a side effect. So relate that back here. Let's talk about the vessels of the lower extremity, starting with the femoral artery, which we talked about already a few times. The external iliac artery continues under the inguinal ligament to become the femoral artery. So your femoral artery, okay, you have this external iliac artery. It goes under the inguinal ligament and becomes the femoral artery. All right? So which artery continues under the inguinal ligament to become the femoral artery? It's external iliac artery. External iliac artery. Which artery?
External iliac artery.
Excellent. And it runs under the inguinal ligament to become the femoral artery. The branch of the femoral artery, deep femoral artery. The deep femoral artery gives off your medial and lateral circumflex artery. So this femoral artery branch, the deep femoral artery, gives off your medial and lateral circumflex artery. So deep femoral artery gives off two branches. Which two branches? Medial and? Lateral. Medial and? Lateral and? Medial and lateral circumflex arteries. This femoral artery enters the adductor hiatus and your adductor magnus muscle to become the popliteal artery. All right? Let's review that one time. This external iliac artery under the inguinal ligament becomes the femoral artery. Okay? This branch, the deep femoral artery, gives off the medial and lateral circumflex artery. And this artery then, this femoral artery, continues under the adductor hiatus into the adductor magnus to become the popliteal artery. What artery does it become? What artery does it become? Excellent. So it's femoral artery. Okay? Let's review that one more time. The external iliac artery goes under the inguinal ligament to become the femoral artery. The deep branch of the femoral artery becomes the medial and lateral circumflex artery. That femoral artery continues then to become the popliteal artery, and you see a good image of that there. It's labeled nicely for you. Everybody follow. The popliteal artery. The branches of the popliteal artery. Your anterior tibial artery. This penetrates your interosseous membrane. It descends in the anterior compartment. So the popliteal artery descends in what compartment? Anterior. This branch of the popliteal artery terminates between your first and second metatarsal as the dorsalis pedis artery. It terminates as the dorsalis pedis artery. Popliteal artery branch, anterior tibial artery, terminates as the dorsalis pedis artery. It terminates as the
Dorsalis pedis artery.
It terminates as the
Dorsalis pedis artery.
But the posterior tibial artery continues with the tibial nerve in the posterior compartment. Let's talk about the veins. Your saphenous vein courses medially and empties into your femoral vein. The saphenous vein empties into the femoral vein. The saphenous vein empties into the femoral vein. The saphenous vein empties into the femoral. The saphenous vein empties into the femoral. Excellent. So saphenous vein courses medially and empties into the femoral vein. You have penetrating and deep veins, and these empty into the femoral vein as well. So the saphenous vein as well as the penetrating and deep veins all empty into which vein? Femoral. The femoral vein. Excellent. Let's talk about DVT. We talked about something earlier. We talked about the Baker cyst that can resemble or have clinical findings similar to a DVT. So the Baker cyst is due to arthritis, right? It can be due to arthritis. This is DVT. What is DVT due to? Stasis, blood stasis, or a coagulopathy. But you see this in clinical vignettes and you hear about it in real life because it's people who aren't active enough, or they're on a long flight, they're not moving. So now if you go on a flight, you'll see in the back seat a little pamphlet of like what exercises to do while you're on the plane so you don't get a DVT. So movement and compression are used now to curb that, and a lot of people have compression socks and stuff like that when they're going to be at risk for DVT if they have a coagulopathy or a coagulation type disorder. What's going to happen in DVT? Well, because it's a thrombosis, because it's a block, it's going to lead to a swollen and red leg. So swollen and erythematous leg and a tender leg, okay? Swollen, red, tender. Swollen, red, and tender. Homan sign. What's the Homan sign? So the Homan sign is dorsiflexion of the foot at the ankle elicits pain. So dorsiflexion of the foot at the ankle elicits pain. Now, the Homan sign is not very sensitive and specific. So if you have a negative Homan sign, that does not mean that you have ruled out a DVT. Okay? So be careful. Just because you have the Homan sign and it's negative, that does not mean that you do not have a DVT. Everybody's probably familiar with the DVT, so we'll move on along now and talk about the compartment syndrome. What's compartment syndrome? It's most common after crush injuries. So, it's common after what kind of injuries? Crush injuries, and it's common in their anterior thigh and anterior lower leg. So anterior thigh and anterior lower leg. Compartment syndrome, crush injuries, anterior thigh, anterior lower leg. What are you going to see? A bunch of P's. Okay? Pain, pallor, paresthesia, paralysis, poikilothermia. Okay, that's a cool extremity. Pulseless and pressure. A bunch of P's. Lower extremity, let's talk about the nerves. The lumbosacral plexus. Let's talk about the lumbosacral plexus. Let's talk about the sciatic nerve first. The sciatic nerve exits inferior to your piriformis muscle. Your sciatic nerve exits inferior to the piriformis muscle. All right? It separates then into the tibial nerve and the common peroneal nerve. All right? Know this. This is important. The sciatic nerve separates into two nerves, tibial and common peroneal. Tibial and common peroneal. Tibial and common peroneal. The sciatic nerve exits inferior to the piriformis muscle and separates into which two nerves? Tibial and? Common peroneal and? Tibial and? Common peroneal and? Tibial and? Excellent. That's the sciatic nerve. The sciatic nerve separates into your tibial nerve and common peroneal nerve. And that's in green, and we highlighted it for a reason. What does sciatic nerve control? Motor control to your posterior thigh and lower leg. Sciatic nerve, posterior thigh and lower leg. Posterior thigh and lower leg. Sciatic nerve is motor to two things. Sciatic nerve is motor to two things. Posterior thigh and lower leg and posterior thigh and sensory to the same part. Motor and sensory to your posterior thigh and lower leg. So we said the sciatic nerve splits into two nerves, tibial nerve and common peroneal. Now it's time to talk about the tibial nerve. The tibial nerve runs in the posterior compartment of the leg. Okay? It approaches the posterior inferior end of the medial malleolus. Okay, of the medial malleolus, and at this part it accompanies the posterior tibial artery. Let's review this. Sciatic nerve divides into two things. Tibial nerve, common peroneal nerve. This tibial nerve runs in the posterior compartment of your leg. It comes posterior inferior end of the medial malleolus and is accompanied by the posterior tibial artery. This tibial nerve divides into the medial and lateral plantar nerve in the sole of the foot. The tibial nerve, motor supply to the posterior compartment of your lower leg, which makes sense because that's where it is, right? We talked about where it was, that's what it supplies motor. And muscles of the sole of the foot. Sensory supplies all of the posterior lower leg and the sole of the foot. Same. Motor and sensory is the same. Common peroneal nerve. This exits the popliteal fossa and divides into two things, the superficial peroneal nerve and the deep peroneal nerve. The superficial peroneal nerve and the deep peroneal nerve. So this is still from the sciatic, right? Sciatic came into tibial and common peroneal. Now we're talking about common peroneal, two parts it divides into. Superficial peroneal nerve and deep peroneal nerve. Let's talk about the superficial one first. The superficial superficial peroneal nerve is around the neck of the fibula and descends posterior laterally. The deep peroneal nerve descends anterior laterally. You see a picture there, so take a look at it. Deep peroneal nerve is motor to the anterior compartment of the leg. The superficial is the lateral compartment of your leg. So we're going to repeat. Deep anterior, superficial lateral. Deep anterior, deep, deep, deep anterior, superficial, deep, superficial. Excellent. It's a common peroneal nerve. This deep peroneal nerve is going to be motor supplied to the anterior compartment of your leg. The superficial one is going to be lateral compartment of your leg. Sensory is going to be anterolateral skin of the leg and your first interphalangeal space. Okay? Anterolateral skin of the leg and your first interphalangeal space. What happens if this nerve is injured? Know that this is the highest yield part of it. If you fracture the neck of the fibula, or if you have a really tight cast on the lower part of your leg, you can injure this common peroneal nerve. Two things can injure it. Fracturing the neck of the fibula. What part of the fibula? Neck. The neck. And what nerve is going to get injured? Common peroneal is going to get injured if you have a fracture of the neck of the fibula or if you have a tight cast on your lower leg. It's going to result in foot drop. Okay? It's going to result in foot drop, which is foot eversion and dorsiflexion, and the patient drags their foot while they're walking. Common peroneal nerve, foot drop. Common peroneal nerve, foot drop. Common peroneal nerve, common peroneal nerve. What causes wrist drop? Radial. So radial, wrist drop, common peroneal, foot drop. Got it? Femoral nerve, of course, with navel and the femoral triangle. Navel from lateral to medial. Nerve, artery, vein, empty space, lymphatics. Nerve, artery, vein, empty space, lymphatics. Navel from lateral to medial. And you see the femoral triangle there. What does the femoral nerve supply? Anterior muscles of your thigh. What muscles of your thigh? What muscles of your thigh? So the femoral nerve does the extensors of your knee. The femoral nerve does the extensors of your knee. The femoral nerve does extensors of your knees. Obturator nerve. Of course, the obturator nerve is in your obturator foramen. What does it motor supply to? All the adductors of your thigh. So, obturator does all adductors of your thigh. The obturator nerve does what of the thigh? Adductors. The obturator nerve does what part of the thigh? Adductors, and it's sensory to the inner part of your thigh. It can be injured in an anterior hip dislocation. We talked about the superior gluteal nerve already. We talked about how it innervates the gluteus minimus and medius and how it can be injured in a posterior hip dislocation. In a posterior hip dislocation. We talked about the inferior gluteal nerve already too. We said that that innervates the gluteus maximus and can also be injured in a posterior hip dislocation. So that brings us to the end of lower extremity.